Hey everyone, in this video we will go through the mechanism of action of various diuretics and how they each affect the four main parts of the nephron that we discussed in our earlier video. If you haven't already watched it, give that video a watch, as it's really important to first kind of understand nephron transport processes before we actually start to understand diuretics. So give that a watch if you haven't, and if you have, let's crack on. So let's start off at proximal convoluted tubule and consider the drug acetazolamide. Acetazolamide, which is a carbonic anhydrase inhibitor, which is this enzyme here within cells of the proximal convoluted tubule. And if you remember, carbonic anhydrase forms bicarbonate to be reabsorbed and also hydrogen to be excreted. So acetazolamide blocking the action of this enzyme leads to less bicarbonate reabsorption here. We get less hydrogen excretion, and therefore, because of this decreased hydrogen excretion into the lumen, we have this apical transporter actually reabsorbing less sodium as well. This means that the overall effect is to decrease the absorption of sodium. We decrease the absorption of bicarbonate, HCO3-, and we also get a resulting metabolic acidosis. And the way to think about this is because instead of reabsorbing the bicarbonate, which is a basic anion, which helps to move the blood towards a more alkalosis, it causes an alkalosis. Instead of absorbing this bicarbonate, we are now no longer doing so, or doing absorbing less, and therefore the pH of the blood is going to be slightly more acidotic as a result. And lastly here we get a hypokalaemia, and our potassium kalemia goes up inside of our blood, and we will come to that and why that happens at the very end when we discuss the collecting duct. Just to be clear, this decreased sodium that we absorbed, means that we are excreting more in the urine. This sodium here remains in the lumen, and remember that water follows the sodium, and so because there is more sodium here in the lumen, more water is going to follow it, and that is how we get the diuretic effect of acetazolamide. Moving on to the loop of Henle, we now consider the drug Frusemide. Frusemide, which acts to block this triple co-transporter here, like that. And what this does is it blocks the absorption of sodium, chloride, and potassium. And the actual effect of frusemide is what's called washout. It washes out the corticomedullary osmotic gradient. The corticomedullary osmotic gradient. And if you remember from renal physiology, what actually happens is in the medulla, it gets more and more concentrated as you go down the loop of Henle. Whereas, and this helps this water here to be reabsorbed, and that's essentially this osmotic corticomedullary osmotic gradient is essentially how water is absorbed in the descending loop of Henle. And so frusemide, when it washes out this gradient, we no longer get that absorption of water in the descending loop. Therefore, our diuretic effect is to prevent water absorption via the blocking of this triple co-transporter. It's important to note though, because we block this triple co-transporter, we lose this luminal positive charge because of the effect, or these chloride ions, these Cl minuses being in the lumen, we kind of lose this positive effect. And this positive effect actually was responsible previously to help reabsorb these cations here, the sodium, potassium, magnesium, and calcium. And because we have a decrease in that positive charge, there is less reabsorption of these cations, particularly the magnesium and the calcium. So the end result of frusemide is to give us a hyponatremia, so low sodium. We get a hypokalaemia, low potassium. We get a magnesemia, and also a hypocalcemia. And this is important because loop diuretics lose calcium, and that's a nice way to remember that. You know, these kind of can help form renal calculi if people are peeing out all of their calcium. So loops lose calcium. Loops lose calcium. Excellent. And very lastly, there is an alkalosis that is associated with these diuretics. And again, we'll come to why this alkalosis occurs at the very end when we discuss the cortical collecting duct. In the distal tubule, we have the thiazide diuretics. So we have the thiazide diuretics. And what the thiazide diuretics do is that they block the sodium chloride co-transporter in the apical membrane, and therefore prevent sodium reabsorption. As a consequence, what happens is that there's a slightly lower sodium concentration within the cells, which means that the concentration gradient for this basolateral transporter is increased, and so you get actually more pumping of the sodium this way in exchange for calcium. And because the activity of this transporter is increased, so there's a nice little increased activity arrow here, the concentration gradient across the apical membrane also increases, and you actually get an increased calcium reabsorption here, and then also acting across this way because of the increased activity here. So thiazide diuretics obviously cause a hyponatremia because they pee out the water. You get a hypercalcemia. You actually reabsorb this calcium, extra calcium. And unfortunately, because of the presence of this chloride, you have a decrease in this positive charge, which again impairs your absorption of magnesium, which keeps flowing out, and so you get a hypomagnesemia. And very much like the loop diuretics, you also have an alkalosis or an alkalotic effect of thiazide diuretics, which we will talk about again when we come to the collecting duct. And it's just interesting to note here that the difference in kind of the electrolytes between the effect of loop diuretics and the thiazide is this hypercalcemia. So thiazide diuretics absorb calcium, whereas the loop diuretics will cause them to be lost or diuresed. In the collecting duct, we will consider amiloride, two diuretics, amiloride, and spironolactone. Which have two separate mechanisms of action. So amiloride blocks ENaC inhibitor, and spironolactone binds to aldosterone receptors. So it's essentially aldosterone antagonist by competitively inhibiting aldosterone function. So what is the effect of these two diuretics? Well, if we block the ENaC, what happens is we decrease our sodium reabsorption. And this causes the luminal charge to go from a negative to essentially goes to a positive luminal charge. And if you remember, it's this negative charge that actually helps to have these potassium ions leak out from within the cell. So what happens is this apical leak of potassium is decreased, which causes decreased potassium excretion. Now, considering spironolactone, remember that aldosterone has three functions. So those three functions were to stimulate the basolateral NAK ATPase. One, it stimulates the ENaC channel to work harder, to absorb more sodium, and also to stimulate this hydrogen ATPase here. So if we have to consider what spironolactone does to antagonize the effects of aldosterone, it's going to decrease the activity of the sodium NAK ATPase, which is going to cause a decreased absorption of sodium. And what it will do is also inhibit the ENaC channel, or decrease the activity of the ENaC channel, causing the effects as noted by Amiloride. And lastly, not to forget, this important HATPase, the hydrogen ATPase, is going to decrease the amount of acid you secrete. So if we secrete less acid, that means the carbonic anhydrase here, there's going to be more hydrogen kind of filling up this cell. And this carbonic anhydrase works on a dynamic equilibrium. So therefore, this bicarb is not going to be made, it's not going to be secreted, absorbed into the blood, because it's going to be here taking up this hydrogen ion. So what you get is a decreased bicarbonate absorption and a decreased sodium reabsorption. And essentially, the effect of this, of not absorbing bicarb, is essentially to put the pH up. So if we kind of summarize the effects here, we get a increased sodium, or I should say a decreased sodium in the blood, whereas we get an increase in the potassium and hydrogen in the blood. And so what this is going to do is cause a hyponatremia, a hyperkalemia, and this is why they're often called potassium sparing diuretics. And lastly, because of this effect here, they cause a metabolic acidosis, because we have less bicarbonate reabsorption, which essentially makes the pH slightly more acidotic. So earlier I promised that I would talk about how loop and thiazide diuretics actually cause a hypokalaemia and an alkalosis, and this is the reason why, the collecting ducts. So loop and thiazide diuretics, if you remember, they cause sodium excretion. And so what happens is that there is increased sodium delivery to the collecting ducts. So there's more sodium hanging around in this lumen here. There we go. More sodium in the lumen. And what this does is it actually stimulates ENaC activity because of this extra sodium. And so more ENaC is going to go through here into the cells, and what this does is it leaves the lumen actually more negative, a greater negative charge here. This means that there's a greater concentration gradient for the potassium to come through and leak out of these cells, and also a stronger or a larger concentration gradient for the hydrogens to also be excreted by this ATPase. So as you can see, if you increase your sodium delivery to the collecting ducts, your distal sodium delivery, so it's called distal sodium delivery, that's the mechanism, increased distal sodium delivery, you cause an excretion of this potassium, so causing a hypokalemia, and you get increased acid secretion, which leaves you with an alkalosis. So that wraps up the video on diuretics. I hope you guys enjoyed it, and I hope you learnt something. Feel free to go back, draw these out. That's what really helped me, kind of drawing it out, ingrains it into your mind. If you have any questions, let me know, and good luck with your studies. Thank you so much.